Everybody. This is my disclosure. So of course, thanks to Dr. Suni for the invitation and Drs. Moran and Neglia for agreeing. And then a brief shout out to some people I know. I wish I was present to actually give grand rounds in person, but we all understand the situation and heed to the warnings from Dr. Neglia. So Brad and I served on the Pediatric Endocrine Society ESAP group. So I'm not sure if Brad's out in virtual land, but hello to Brad. Two of our former CHOP fellows, now attendings with you guys, are Megan and Arpana, so hello to them. And then Kiki and I wrote a chapter for her textbook, which I guess there's two versions. The most recent version was in 2016, Pediatric Endocrine and Inborn Errors of Metabolism. So if you're on the call, hello to all of you, and hopefully everyone's well. So this is the outline. I'm going to kind of go over how we got to where we published our guidelines, which were in 2015. So just a brief history to put this in the context. What you'll notice is there was some things that happened and then this big gap for about 40 to 50 years. It wasn't that people weren't providing excellent care over that time. It's just that there weren't a lot of historic landmarks during that time. And you'll see what I mean as I go through the next couple slides. I'll go through then the guidelines, how we've used them to stratify care. We're starting on the second version of the guidelines now and hope to have those published hopefully by the end of next year. A little bit shorter time frame than it took when we started the first version from start to finish. And then bring up some things that we're now using moving forward. And I think most of this has to do with oncogene specific therapies and identifying the driver mutations associated with thyroid cancer. So you can, one, not just improve diagnostics, but hopefully improve stratification of therapy and then individual therapy for patients that have progressive non-responsive disease. So it really has been a journey over the years. In the 19th century, in the 1800s, this was a fatal disease. And most of the fatalities, if you just look through the slide real quickly, just looking at the year, and then looking at the second column, many of these were operative mortalities. So the initial improvement to care was in the surgical realm. And it was Theodor Kocher who really was at the forefront of this. In 1883, there's about an almost 13% mortality rate. And by 1898, the mortality rate is down to 1%. So huge improvements over that time. And if we talk about high volume surgeons, Dr. Kocher would certainly fall into that category, 7,000 thyroid surgeries over his lifetime. And ultimately in 1909, he was awarded the Nobel Prize in Medicine for his work in the realm of thyroid and improving care for patients. In 1913, the first thyroid unit was established at the Mass General, and by 1941, Saul Hertz identified that radioactive iodine can be used to treat Graves' disease patients. Within that same decade, in the late 1940s, radioactive iodine was then used to actually treat a thyroid cancer patient, which you can see in the center of the screen, the pre and post treatment, that had metastatic thyroid cancer, even to the skull, and you can see the marked improvement and the identification that radioactive iodine is a highly selective and highly effective form of treating thyroid cancer that is not surgically resectable. In the late 40s also, fine needle aspiration was introduced that ultimately helped define who should benefit from, who could benefit from surgery and what surgical intervention would be most appropriate for that patient. In 1950 is when the pediatric kind of history came into the time frame, and Duffy and Fitzgerald raised concern that radioactive radiation can induce thyroid cancer. And at that time, radiation was being used for simple things like tinea capitis, tonsillar hypertrophy, even acne treatment. And it was low dose radiation that seemed to be more impactful than high dose radiation. So the thyroid is very sensitive to radiation, especially prior to age 16 years of age. After that, it becomes less sensitive. So adults are less sensitive than pediatric patients. And it was really in the 50s when that was identified. By 1956, Winship published really the seminal article that raised the awareness for pediatric thyroid cancer. And in that article that was published in Pediatrics, the essential summary was all thyroid nodules should be removed. So we've come some distance from that initial recommendation. But even then in the 1950s, if we looked at in the United States what was going on for the care of children with thyroid disease, 94% were being treated surgically. Many patients, at least a third of patients, they didn't have adequate preoperative imaging, and so at least 30% required a second surgery, and 20% were receiving therapeutic radioactive iodine. 17% of patients still died of disease, and 9% of those patients were dying after surgery. So even in the 50s in the United States, there was a high mortality associated with the diagnosis of thyroid cancer in children, and much of it was due to therapy, and at the time, at least what was reported, surgical therapy. Interestingly, in 1956, which is not surprising, the quote in the article suggests that there's very little agreement concerning how to best care for these patients. So in 1959 is when medullary thyroid cancer was identified, and by 1967, thyroid ultrasound was introduced into clinical practice, and that's been a huge benefit to the patients so that we can, one, decide if someone needs a biopsy, and two, then do preoperative planning that's complete so that the patient, when they go to the operating room, the goal is one surgery that's complete by a high volume surgeon with a low risk of permanent complications. In 2006, this is now almost 40 years after Saul Hertz, the American Thyroid Association published adult guidelines for the treatment of adult patients with thyroid cancer, differentiated thyroid cancer. And the year after that, Scott Rifke's, when he was at Yale, established the first thyroid program within the United States. Our program was established in 2009. I was still on active duty in the Army. And so the program at CHOP has been a work in progress now for the last 11 years. At the end, I'll show you some of the things that we're working on. But in 2010, when the second edition of the adult guidelines came out, there's this paragraph that essentially said something that almost all of us as pediatricians don't like. It's kind of crawls under our skin, that we should treat children very similar to how we treat adults. And there's clearly a risk and not an optimal care when one takes that approach. And so three of us, Stephen Wagaspat, my mentor, Gary Francis, and myself, approached the ATA and essentially lobbied that we could create pediatric-specific guidelines. And so in 2010 is when we did that. It took till 2015 to finally get them published, which is about 60 years after the Winship article. So now we have our first, at least, attempt. They're not perfect. They are guidelines. There's no rules or laws associated with them. But the goal of the guidelines was to try to improve care, try to improve a unified approach to care, or at least a unified way of thinking, and to start stratifying care, mostly for our first version of the guidelines in regard to radioactive iodine. And there was already a movement in the adult population that not all patients benefit from radioactive iodine. So why we developed the guidelines? Well, we knew that the pediatric patients looked very similar to adult patients as far as how they present. An asymptomatic nodule is the most common presentation. We knew when we looked at the thyroid lesions under ultrasound that they look very similar. If you look under the microscope after fine needle aspiration, there are also many similarities, although there are some differences between pediatric and adult cytopathologic diagnoses. Histologically, very similar. If you have classic papillary thyroid cancer, follicular variant papillary thyroid cancer, solid, tall cell, they all look the same, whether it's an adult or a pediatric patient. But we also realized that there's more and more patients that are being diagnosed with it, and that was being witnessed in the adult population and also witnessed in pediatrics. So in a paper that came out in 2015, now 6 years ago, pediatric thyroid cancer was amongst the highest, I think it was in the top 3, of solid tumors that were being diagnosed within the United States. So the highest incidence increase within the top 3 of solid tumors within the United States. For some reason, there's very little data from the Midwest, but my guess is it would follow a similar pattern. So 4 to 6% per year increase rate of diagnoses. Most of the patients that were being diagnosed, this is now a couple years prior, but this SEER data from the National Cancer Institute showed that was in the adolescent population. So the 3 areas on the graph here that you can see is 5 to 9-year-olds, 10 to 14-year-olds, and 15 to 19-year-olds. And that's where we see the majority of our patients being diagnosed. Mostly actually in adolescent girls as well. So you can have patients as young as 3 years of age with differentiated thyroid cancer, but clearly in the most common group of patients that are being found to have thyroid cancer are adolescent girls, some are peri and post-pubertal. So what were differences that kind of pushed us to get the ATA to publish guidelines? Well, when we looked at the data that said, if you have a nodule, before you do the ultrasound, before you do the biopsy, what's the likelihood that that nodule is going to be malignant? there was clearly an increased rate of malignancy in a patient of pediatric age, less than 19 years of age, if they were found to have a nodule. And those numbers were about 3 to 5 times different. So the risk of malignancy in adult is somewhere around 5 to 10%. And if you look at all the data, this is just a cumulative summative data in 2006, but it's been shown since that time too to have a 2 to 4-fold increased risk, even from doing ultrasounds and FNAs within the same institute that look at adult and pediatrics. It bears out across most of the studies. There's a 25% on average risk that a nodule in a pediatric patient will ultimately be found to be malignant. The ultrasound can be used to sway that malignant rate. So sometimes we look at ultrasounds and we can say that's less than 5%. Sometimes we look at ultrasounds and we say that's greater than 90%. And then after ultrasound, of course, is fine needle aspiration. So we get a lot of information before surgery, but nothing obviously is as nothing is as good as a gold standard as surgical pathology. But the goal is not to remove all nodules. Other differences are the increased rate of metastasis. So pediatric patients have a higher rate of metastasis to central lymph nodes. The oncogene prevalence is much different in pediatrics than adults. Point mutations in BRAF are more common in adults. Fusions are more common in pediatrics. The differentiation of a tumor is different between adult and pediatrics to the benefit of most of our pediatric patients. So most patients maintain differentiation, which by definition, we're mostly talking about sodium iodine symporter expression and the ability for the differentiated thyroid cancer to absorb radioactive iodine. So most of our patients are RAI avid and can be treated for disease that's left post-surgery. Rate of complications, though, was not to the pediatric favor. There's more complications in pediatrics, and it's probably because there's just less experience medically and less experience surgically for caring for these patients. And then the other thing that's not of benefit to the pediatric group is a risk of recurrence, and I'll show you both of these rates. So this is just, again, a summative data looking at what's the rate of metastasis between adult and pediatrics. So bilateral disease, pretty common in pediatrics, even occult bilateral disease. So we just published this year about 170 thyroid cancer patients, pediatric patients. 38% had bilateral disease, and 23% of that were occult. So the ultrasound did not identify microscopic papillary thyroid cancer in the contralateral lobe, but it was there on post-surgical analysis. Regional metastasis, again, most common in the central neck, followed by the lateral neck, and then from lateral neck to pulmonary is the typical lymphatic drainage and the pattern of metastasis in pediatrics. If we look at pediatrics, regional metastasis about 50%, and looking at adults, it's about 15 to 30%, so a higher rate. And if you take patients that have had lateral neck lymph node metastasis, they have about a 15 to 20% risk of pulmonary metastasis in pediatrics. So the range is 6 to 20% and much lower rate in adults. As far as recurrence, this is a study now from the Mayo, from Hay, but there is also another study from the UK by Landau showing about a 30 to 40% likelihood of recurrence over a patient's lifetime. The patients ultimately did well, but that just drove home that one, whatever we do during the pediatric age frame, as far as stratification of care, we should be cognizant to say we don't want to increase the rate of recurrence or even persistent disease, which we can argue about if it's persistent or recurrent. And we also want to convey to the patients that no matter what, if they look like they're doing well in pediatrics, it looks like they're in remission, they need lifelong follow-up. And that comes down to at least labs once a year. And if they've had a thyroidectomy, they're getting a TSH at least once a year anyway. So they should get a thyroglobulin and an antithyroglobulin, which are our tumor markers in patients with papillary or differentiated thyroid cancer. But because of the metastasis, because of the recurrence rate, there was a basic, more aggressive approach to patients before the guidelines. So there's a increased rate of malignancy, metastasis, and recurrence. And because of that, prior to the guidelines, many patients were treated similarly. If you had a nodule, you had surgery. If it was identified to be a thyroid cancer or a high risk of thyroid cancer, every patient got a total thyroidectomy. If you had thyroid cancer, every patient got radioactive iodine. And if you had persistent disease, you'd go back to the OR. If it was non-surgical, you'd get radioactive iodine. And even during training for me 20 years ago, we were giving radioactive iodine almost every 6 months for patients that had pulmonary metastasis, trying to get rid of the pulmonary metastasis as defined by thyroglobulin levels and by nuclear medicine or CT imaging. And we would just keep giving him and giving him and giving. And there still are some countries that have guidelines that give radioactive iodine much more frequently than we've now decided to use in the United States. So in the backdrop of all of that was this realization that kids with differentiated thyroid cancer actually do well. Very low disease-specific mortality, very high disease-specific survival. So more than this is now less than 20-year-olds to the left of this graph, this bar graph, 98+% of our patients do not die of disease, not just in the pediatric timeframe, but at least for the follow-up data that we have, at least 30 years post-diagnosis, if not beyond. And within that, we started to say, well, if people are doing really well, despite them having high risk of malignancy, high rate of metastasis, high rate of recurrence, what's their complication rate, and is it worth it to be this aggressive? So this was a study that came out in 2008, looking at what's the risk of complications. This was surgical complications based on national insurance data. So overall, the younger the patient, the higher risk of complications, the longer the hospital stay, the higher the cost. And the two main surgical complications that we use as far as metrics are recurrent laryngeal nerve damage and permanent hypoparathyroidism resulting in hypocalcemia. And it's much, much easier to treat hypothyroidism than it is to treat hypoparathyroidism. So at all costs, we need to try to reduce that. And we also need to try to reduce bilateral recurrent laryngeal nerve damage. I have one patient that I still see currently who's on systemic therapy that is trach dependent because of bilateral recurrent laryngeal nerve damage. So we do not recommend purposeful sacrificing of nerves. That used to be something that we would do if the tumor encased the nerve in the effort to try to maintain recurrent laryngeal nerve integrity. So the goal of surgical risk is to reduce both of those complications. Radioactive iodine was used quite frequently, as I already suggested, but we started to realize that despite radioactive iodine, and if you just follow some of these dotted areas that I've highlighted, the more you use it, the lower the recurrence rate. And it's not perfect, but if you look at all those numbers, there's actually there's a fair correlation between that. And so radioactive iodine is associated with a lower risk of recurrence and improved accuracy surveillance. So if you don't have any thyroid remnant left, you can use the thyroglobulin a little bit more to predict if you have persistent or recurrent disease. And so over that time frame, we started to say, well, how many patients are getting radioactive iodine, and what's the impact, long-term impact for the patient? And you can see between 1970 to 1980 and then 2000 to 2008, how many patients were receiving radioactive iodine. This is now patients under 25, so pediatrics and young adults. And there was a huge gain, a fourfold increased use in radioactive iodine. But when we looked at disease-specific survival, not much of a difference. Survival was essentially the same. So no change in disease-specific survival. And then we started to look at complications of radioactive iodine, and there's both early, there's intermediate, and there's the long-term complications. So the kind of early and intermediate ones are cellulitis and parotid or salivary gland dysfunction, which is very difficult for patients to deal with. The production of adequate amounts of saliva is important for dentition, it's important for speech. So that's something that we try to avoid. And then of course, long-term, the repeated use of radioactive iodine increases the risk of pulmonary fibrosis. And then there's some data, which we won't have time to go into completely, that suggests that there may be an increased risk for radioactive iodine-induced second primary malignancies, not thyroid-related. So the question, of course, is risk and benefit, and there is some concern for benefit, as I mentioned, but also for risk. So our guidelines were designed, the first version, and the second version will work on what we did for the first version to reduce complications. We mostly focused on medical radioactive iodine. The second one, we're going to start looking a little bit more surgical to reduce surgical complications as far as every patient need total thyroidectomy. We wanted to maintain low disease-specific mortality, achieve remission, and then to avoid increased risk of recurrence. So the guidelines identified that if you have a nodule, you should biopsy it, and then you should use the biopsy to determine what the right approach to care is. For surgery, we essentially said all papillary thyroid cancer is the same. I don't believe that that's true. But because of that in the first version, that almost all patients get a total thyroidectomy, and because of the higher rate of central neck lymph node metastasis, that you remove lymph nodes as well. In adults, they have, and they continue to kind of move away from that because they're worried about the risk of complications. But in pediatrics, we don't use it to change disease-specific mortality, which is not a good metric in pediatrics, as I already mentioned, but to help define what's the behavior of the cancer. So we have many patients now, and there's a recent publication from the Ito Hospital in Japan, where some patients are now undergoing lobectomy with an ipsilateral central neck dissection, and then using that information to decide, is it worth going back to remove the contralateral lobe? Is it worth going back to remove to administer radioactive iodine? So there's still a lot of work to be done within both the medical and the surgical fields for improving the care for pediatric patients. Radioactive iodine, as I already mentioned, it is the most effective therapy, has a low risk if it's used cautiously and at the right dosing and the right frequency. But we still raise the question, do all patients benefit? The one thing that we also did in the guidelines, which took some discussion with the executive board at the ATA, was we insisted on defining what a high volume pediatric thyroid center should include as far as a metric that was measurable. And at the time, all we had was really surgical metrics based on some national guidelines, again, from insurance companies. So we defined it as more than 30 endocrine neck surgeries a year, which we understand was hard for smaller hospitals. But because of that, we recommended that there's a regionalization of care. So this is one of those diseases. There's excellent surgeons everywhere, but it's, again, a surgery that has a high complication rate. And the more you do something, most times you're better at doing it. And then also, if it's at a high volume regional center, you can help, you're more comfortable stratifying care, both surgical care and medical care. And so 4 years after the ATA guidelines, there's now an increased number of thyroid programs. And the biggest challenge I see from centers that I visit, or now in virtual land, in person or in virtual land, is that it's hard for people to want to give up, especially surgeons, that they don't, that they give up a case, especially a case that they don't see very often. And so that's a big political issue, I think, at many centers. At our center, was quite easy because one of our two thyroid surgeons is the surgeon in chief. And when Scott Adzik said it's going to be Ken Kazahaya, who's a head and neck surgeon, and myself, it was quite easy. From there on, the rest of the surgery department fell into line. And within endocrine, most of my colleagues here at CHOP, when we have about 30 plus pediatric endocrinologists, we're very happy to give up the thyroid nodule thyroid cancer patients. And then we share most of the other thyroid disorders except for resistance syndromes. But it is doable, and I think there is a huge benefit to hospitals investing in identifying one or two people within certain specialties to help improve the care for pediatric patients. So you can see this list here, and there's more and more of them at Duke and across the board. And one of the things I'll close with is that we've now created a National Child and Adolescent Thyroid Consortium where we're trying to work together to use a clinical registry and to also have a biorepository so we can improve the understanding of the molecular landscape of pediatric thyroid nodules and thyroid cancer. So let's move on to how we're set up at CHOP just real quickly. So this is what we have at CHOP. Before I started the Thyroid Center, patients would come in either through surgery, ENT, or endocrine. Oftentimes they'd go to the OR and then they would come to endocrine. Now it doesn't matter where they come through, they all come back to endocrine, the Thyroid Center. I'm the main pediatric thyroid person. I have one other colleague who I work with who's both endocrine and onc board certified, Goli, Mustafi Moab. So we have a central access point. We do all the preoperative evaluation, and then we decide if they need a biopsy. We interpret the biopsy. We provide the surgical plan. They go back to one of our two surgeons. We try to split them. And we've incorporated a number of clinical tools to help improve evaluation. When we do biopsies, they're read in real time by our cytopathologist who's at Hub because we have video connection to the microscope and the interventional radiology suite. We can do non-surgical destruction of permanent lymph nodes and of benign nodules. So there's many things here which we don't have time to go into each individual one, but all of them I think are, one, exciting because I love doing this, and two, to the benefit of patients. In 2017, which I'll show you at the end, I established an advanced pediatric thyroid cancer therapeutics clinic because we are identifying patients that don't respond to radioactive iodine that have progressive disease. And there's really a bunch of wonderful oral systemic chemotherapies that have been used in adults, have been used in other cancers that are now being used in the treatment of adults with progressive thyroid cancer, as well as in pediatrics. Last summer, I was lucky to hire a R01 funded translational scientist, and now we have what I think is the first pediatric translational science program in the country. Amy has brought in 2 other postdocs. We have about 10 people in the lab now, postdocs and students and technicians, 3 mouse models, RAS-BRAF, NTRK fusion, and we're trying to add a RET fusion, and a large biorepository of over 300 samples just from CHOP, and the first pediatric thyroid cancer cell lines that we're getting from patients that consent to obtaining a viable tissue sample from the OR. So we see a bunch of patients. I never thought I could be a pediatric endocrinologist and just see thyroid patients, so it's quite awesome. And the more I see them, the more I learn, the more comfortable I get with this. But every time I see somebody, there's always obviously something new to learn. And I talk to people across the country, and all those interactions I love, and I think that's really important for us to grow our community. And it's as beneficial to me, hopefully, as it is to the people who contact us. We're now above almost 700 thyroid surgeries since we started the program. So we average around 60 to 70 plus thyroid surgeries split between our 2 surgeons a year, and probably over now treated at CHOP 400 thyroid cancer patients. We get about 2 to 3 new patients per month, and we've been doing this now for almost 11 years. So it really has been if you build it, they will come, and I think that's true for other centers that have been developed. Our complication rate has dropped. Before the thyroid center, we had like 2 or 3, maybe 5 patients a year have thyroid surgery. And when we publish these, now this was under 500 thyroid surgery patients, we have a less than 1% complication rate. And that's held true even out to now, just over 700 thyroid surgeries. And our average hospital stays about 2 days now because of some guidelines that we put together how to manage post-op hypocalcemia and how to prevent it and identify it early, so to decrease the rate and the length of hospital stays. So how do patients present? The most common, as I said, is an asymptomatic nodule. The exam, I think, even though I was taught in medical student, exam from behind the patient, just because the way our clinic is set up, that's an impossibility. I'd have to pull the table away from the wall. But I still think it's an exam that's better from in front of the patient, because inspection is such a huge part of this exam. So you have them, you're looking at the patient, they look up. Well, first chin neutral position, then they look up. And then when they're looking up, you have them swallow if they have enough saliva, or if you give them something to drink. And you can learn a lot about the thyroid gland, whether it's a nodule, whether it's asymmetric, whether it's normal, just from those 3 steps. And then you move into palpation. The thyroid lives in the central neck, which is designated level 6. And then if you look at lymph node metastasis, the most common area is level 6 behind the thyroid, followed by levels 2, 3, and 4. 1 is almost never involved submental unless you have a thyroglossal duct cyst associated papillary thyroid cancer, and level 7 sometimes, and that's hard to distinguish 6 to 7 because 7 is right at the sternal notch in the mediastinum. Level 5, again, which is the posterior triangle where everyone likes getting a neck massage, is possible, but it's probably 5% of our patients that have metastasis there. So when an ultrasound is performed, if a nodule is found, you need to make sure that the ultrasound includes not just the central neck, which has a low sensitivity because the thyroid's in the way of identifying pre-surgical lymph node disease, but inferior to the thyroid, you can see them. I have an ultrasound machine in clinic. I do my own ultrasounds. And in the lateral neck, it depends where the nodule is. But you need to look at if it's a lower lobe nodule versus an upper lobe nodule. Lower lobe, you need to look at levels 3 and 4. Upper lobe, you need to look at 2, 3, and 4. So the ultrasound has to include the lateral neck if you're sending a patient for biopsy. So if the nodule is so concerning an ultrasound that you're thinking about biopsy, the ultrasound needs to include a full assessment of the neck, which includes the central and the lateral neck. And when the biopsy is performed, then you should at least biopsy at least 1 lymph node from each level if there are any lymph nodes that are concerning. You don't have to biopsy them if they're normal in appearance. And realize that our pediatric patients, all of us, probably have 250 plus lymph nodes in our neck. So you're not looking for normal lymph nodes, you're looking for abnormal lymph nodes. So this is a normal exam. When someone looks up, you cannot see their thyroid, which is located essentially right below this crease. Here's a patient with a nodule that most of us wouldn't miss. So this is a patient actually with Graves' disease, has a huge nodule. In chin neutral position, as you can imagine, you would see that as well. We published how, at least my approach, which is just an approach, it doesn't mean it's the only approach, how to do a proper exam. And then we had some patients that were nice enough to allow us to create a YouTube video. This is one of our patients preoperative that had lateral neck lymph node disease with displacement of her left sternocleidomastoid. So it's at least a reasonable first approach at how to do an exam, and you can learn via video. We also have patients that are found just because of head and neck imaging. So it's not really what you find, it's not really how you find it, it's what you find. So this is a patient that's totally unluckily woke up in the middle of the night and felt something stuck in her throat, and ended up being part of her retainer that had broken off, and she accidentally swallowed it. That's what the little square is. But when she came in on the plain film, they noticed that she had tracheal deviation, which you can see here. And that was because she had massive asymmetry to her thyroid and massive bulky lymphadenopathy from metastatic papillary thyroid cancer. So it doesn't matter, and she was asymptomatic. I just saw her actually 2 weeks ago. She's in remission, doing really well, but it's not how you find it, it's what you find that's most important. And then for all the general pediatricians, this is really important. So persistent cervical adenopathy, yes, infection, infection, infection. But when you start to look at level 3, level 4, especially if it's an adolescent, this is a pre-adolescent girl, one of our patients, but in adolescence, you need to think about thyroid. And before you do an excisional biopsy, at least have the ultrasound look at the thyroid and look at the lymph node. And that can be easily determined to be or not papillary thyroid cancer. And then rather than having an incision here and an incision down here, they would have one surgery that would be the proper surgery. So thyroid ultrasound before excisional biopsy, super important, persistent cervical adenopathy. And then we have some high-risk patients, and we can talk about this, but there isn't a full consensus on oncology survivors that have been exposed to radiation, but we do know that the younger the age at the time of exposure, we do know that sex also has some predisposition, so female sex a little bit more common. So less than 10 years of age at the time of exposure, there's an increased risk of developing differentiated thyroid cancer. Again, the most common would be papillary thyroid cancer. So I'm a firm believer in ultrasound surveillance of high-risk patients, and I think these patients within 3 years should be at least having physical exam, and 3 to 5 years having at least their first ultrasound. On the earlier side, if they're less than 10 years at the time that they received head and neck radiation for a treatment of a non-thyroid related malignancy. As I mentioned earlier, the lower dose is more tumorigenic to the thyroid, so it's kind of a linear relationship. And when you start looking at doses that have been used for total body radiation, that's kind of where the peak is as far as the risk for radiation-induced thyroid malignancy. And if you go above that, you start to cause sclerosis, and it's still at higher risk than if you didn't have a radiation exposure, but the slope of the curve starts to decrease. And then there's a bunch of syndromes, which again, because of time, we won't go into all of these, but we do have guidelines that suggest earlier surveillance for some of these syndromes that are the differentiated thyroid cancer syndromes. And some of those I think we need to look at because most of these are associated with less invasive disease. Medullary thyroid cancer, of course, MEN2B is associated with very early onset, even prior to age 1 year of age. So there are tumor syndromes. It depends which one as far as when you should initiate surveillance. And as I mentioned, the majority of the differentiated ones associated with minimally invasive disease. There is a back and forth about data, and it kind of depends on what article you want to read. But if you have autoimmune thyroid disease, there is an increased risk of nodules that I don't think you should ultrasound all your Hashimoto's patients. But for a Graves' disease patient that you're trying to decide on definitive therapy, we ultrasound everybody and use that information to decide if they'd be a candidate or not as one of the factors, a candidate or not for radioactive iodine or surgery. So at least to think about when to use ultrasound. So in Hashimoto's asymmetry, you think you feel a nodule, you have abnormal lymph nodes, fine, but not every Hashimoto's patient. All right, so not all nodules are surgery. Ultrasound is super helpful. I'll just show you real quickly what we're using now to help stratify the use of ultrasound for biopsies or not. In the first version of the guideline, we did not go into specifics. We said just do an ultrasound. But thankfully, the adults have a pictorial atlas within their version of the ATA guidelines. And I think most of us now are using this TI-RADS system, which is based off of BI-RADS, which was breast imaging, but this is TI-RADS for thyroid imaging. And there's nothing magical about this. It just looks at 5 different characteristics of a nodule, and you use those characteristics to decide risk or not risk. The most helpful composition as a single feature is composition. So if it's all cystic, it has a very low risk. If it's all solid, it's at least intermediate, if not higher risk. Then you look at, is it brighter gray, same gray, or darker gray? Is it taller than wide and transverse imaging, not sagittal but transverse? Are the margins smooth? And are there any evidence of bright spots? The difference in adults is we do not use size to help determine if someone should have a biopsy or not. So I think these are all applicable across, even in pediatrics, even though most of the studies are in adults. The exception is do not use size to determine if you should or should not do the biopsy. As I said, composition is a single most reliable feature to help stratify the risk for malignancy. And this is an article we published in 2018. There's another article by Gupta et al. From Boston that had a similar finding the year prior to ours. As far as FNA, we use the Bethesda system for reporting thyroid cytopathology. It's a 6-tiered system. And just like in adults, unfortunately, about a third of our patients end up in the gray zone. And patients need to understand that before the biopsy. It's not nice to go to the biopsy thinking it's a yes or no answer, and then you tell the patient, we don't know, even after you stuck a needle into their thyroid. And so you have to explain to them that we're only looking at cells, we're not looking at tissue. And there is a percentage of patients that come out of a biopsy and we don't know. The difference between adults and the Bethesda system, of course, was created in adults and kind of validated in adults. And now there's an increased number of reports on using this within pediatrics. But here's the challenge. These are, again, the columns. So this is category 3, category 4, category 5. And the risk of malignancy, which in adults is 5 to 15 for category 3, as you can see here, 10 to 40 in category 4, if you based on the most recent Bethesda criteria. But look at the variability within pediatrics. These are now different studies from different institutes. And so the take-home point from this is it's super important for you to know what your risk of malignancy is within your institute. You cannot just rely on the Bethesda categories. And 2, we need to do a better job. We need to come up with an atlas that allows us to hopefully improve the sensitivity, specificity, positive and negative predictive value across pediatrics. And that's one of the things that we're starting to work at now at CHOP, is a free web-based thyroid atlas that will be case-based, that can be used by students, residents, fellows, cytopathologists, to help us hopefully get to a better point where there's not such a variation within these categories. So at CHOP, this is our rate of malignancy. So Bethesda category 3 is about 20%, 4 is about 40%, and our 5, which is suspicious for malignancy, is very close to our 6. So you really have to understand what yours is at your institute. Within the intermediate, that gray zone, these are the most common diagnoses, which is the same in adults. The majority, if you're a category 3, will be benign. If you're category 4, it's somewhere around 50-50 or 60-40, depends on your rate of malignancy. And then there's the other ones are kind of low invasive forms of thyroid cancer, and then very uncommonly, but possible, you can also get classic PTC. So in 2015, even in our guidelines, you essentially, if you're in the gray zone, have to remove half the thyroid to figure out what the diagnosis is. Well, that's not very satisfying if it's benign, because it might have been followed. And it may not be adequate. It's not satisfying if it's malignant, because if it's an invasive form of classic PTC, then you may have to go back and do a completion thyroidectomy. So in adults, they've started to use preoperative molecular testing. There's 2 different ways of doing this, or actually 3. One is looking at the oncogene driver mutation, and there's a number of different commercially available panels, and some are institute specific. And then there's gene expression classifiers, now called the gene sequencing classifier, which has not been approved under age 21. And microRNA and Thyromere is one of those. These have not been used in pediatrics, so these have been, and I think they're actually quite helpful, even though in our guidelines, the first version, we weren't very committed. We couldn't come to a consensus on if they were could be used in pediatrics. We just didn't have enough data. So that was the recommendation from our initial guidelines. Insufficient data to say that these are helpful, but in 2020, I absolutely believe that using these are helpful. And that's because we now have increased amount of data to know what the molecular oncogenic landscape is within pediatric PTC and somewhat for pediatric FTC as well. So you can use these knowledge of the preoperative knowledge of what the mutation is, whether it's a fusion or whether it's a point mutation, to help decide what's the risk of malignancy, and even to help decide is a lobectomy adequate or is a total a better decision. And these are proposed from 2 different studies that I've published that need to be prospectively validated. So is there a genotype and a phenotype correlation, and does it predict invasive disease? Those are the two things that we would need to confirm to be able to use this preoperatively. And I think there is enough data now, and it's accumulating, that that is true. So we can guess what the surgical path will be, the surgical histology, and we can even predict what's the risk of malignancy, risk of invasive behavior based on knowing what the molecular oncogene is. So BRAF infusions are more likely to have lymph node metastasis. RAS, Dicer1, P10, somatic RAS, somatic Dicer1, somatic P10 are less likely to have lymph node metastasis. So RAS, P10, Dicer1, maybe lobectomy, no central neck, fusions, and BRAF mutations, likely a total thyroidectomy is a better move with an ipsilateral central neck dissection. Even within the same histology, this is now looking at follicular variant papillary cancer that can be encapsulated or can be more widely invasive. If you look at patients that have more widely invasive follicular variant PTC, they're more likely to have fusions. So NTRK3 ETV6 fusion or RET PTC 1 or 3. So the knowledge is really, really powerful. This is data now that we've been working on to publish this for a little while, but hopefully in the next month we get this in. Again, kind of laying out that if you have these mutations, what's the likelihood of central neck or lateral neck metastasis, and the likelihood of distant, which is mostly pulmonary metastasis. So I think it's a yes and a yes. Here's an encapsulated isoechoic solid nodule that it's a non-invasive or benign lesion, most likely to have a RAS Dicer1 P10. Here's a patient that has, this is now looking just at the left lobe, diffusely infiltrative lesion with echogenic foci, which are microcalcifications in a lymph node in the lateral neck that looks just like that. This is likely to be diffuse sclerosing variant PTC and highly likely to have a fusion, whether it's RET PTC or an NTRK fusion. So the surgical approach you can use, I think we do need to prospectively confirm this, but there are an increased number of data to help support that just in the last 1 or 2 years to use this information, not just for improving diagnosis, but to stratify care. So the key points for optimizing surgery, of course, is complete imaging, which I hope I conveyed earlier, accurate biopsy and knowing what your risk is at your own institution, and then having someone where the risk of complications are low. Radioactive iodine, and just to move into the final part now, is a very helpful and very selective cidal therapy within differentiated thyroid cancer. There is not staging in the sense that oncology staging occurs because the metric of disease-specific mortality is so low. So in thyroid cancer, there's 4 stages. And if you were a 55-year-old and I had lung metastasis, I'd be stage 4. But if I was a 10-year-old and had pulmonary metastasis, I'd be a stage 2 because you can't be anything above a 2 within pediatrics. So it's just not a helpful system within pediatrics. But we do use the T&M classification to help define what the behavior is based on surgical path. So the T part of it is how big is the tumor and what's the evidence that it was spreading outside of the thyroid. The N portion is, did you remove lymph nodes? If you did, were any of them positive? If any were positive, is it the central neck or lateral neck? And the M is, did you do any imaging to know if you have distant metastasis? Would be MX, would be if you didn't. If you did, but you don't have any, it's M0. If you have distant metastasis, it's M1. So we identified and proposed this. If you were low risk, that's based on disease confined to the thyroid, minimal central neck disease, you may not benefit from radioactive iodine versus intermediate and high risk. So this is from the 2015 version. But we also, since 2015, have realized that while it's very effective for most, it's not very effective for all. So not all patients benefit, even patients with advanced disease. So there are patients that have persistent lymph node disease, and at least 1/3 of our patients, if not more, maybe even 2/3 of our patients that have pulmonary metastasis, we can't get rid of it with radioactive iodine. It may not be growing. We call it stable persistent disease, but there are a number of patients now that, one, despite repeated radioactive iodine, the disease continues to grow. And if you use more of it, it still doesn't matter, it continues to grow. Whether it's absorbed the radioactive iodine, in some patients it still grows, or whether it doesn't, it's lost the ability to express the sodium iodine symporter and it doesn't absorb radioactive iodine anymore. So here's just the first example that led me to create this advanced thyroid cancer therapeutics program. This is a patient that presented actually for an evaluation of strep throat, and a very astute nurse practitioner noticed this massive gland. It was firm. She was ultimately identified with diffuse sclerosing variant PTC with lymph node metastasis. She had surgery, she had radioactive iodine, but despite a second surgery and a second dose of radioactive iodine within the first 15 months of diagnosis, her pulmonary metastasis just continued to grow. And if I showed you her whole body scan, her lungs lit up. She has avid disease, but the cancer doesn't care. It's continuing to grow despite radioactive iodine. So I knew that I was running out of tools, and I knew that there were some newer drugs that are being used in the adult population. So I contacted our thyroid oncologist at our adult hospital and set up a clinic to help identify which drug should be used. Just this last July, we published an article in JAMA Pediatrics, Oto Head and Neck, that identifies what some of these agents are, what are their targets, and how should we start to think about how could we use these things within pediatrics. So here's the sample, the initial program, and now just this last month, we're moving this over to CHOP, and Ted Latch and Frank Ballas are helping me to set this up at CHOP. They're part of our developmental therapeutics program. So we're going to have a joint program where we work with Dr. Brose, adult thyroid oncologist, and our own pediatric oncologist to help provide better care for some of these patients that have progressive disease. Our first patient, as I showed you, this is pre-lenvatinib. This is a tyrosine kinase inhibitor with her bulky pulmonary disease, and this is 2019, and even the scan from 2020 looks even better. So she's stayed on lenvatinib and doing very well. She has no symptoms, and if she progresses, we know she's a RET PTC fusion positive patient, and there is systemic therapy now that's very effective. That's oncogene specific targeted therapy and FDA approved to use in her age group. She's now 19 years old. Last, here's a patient that has medullary thyroid cancer that ultimately was intubated because of airway compromise, and has never even undergone surgery, because once MTC metastasizes, you can't get rid of it, but was identified to have a rare fusion. Fortunately, it was targetable with a ALK inhibitor, and this is what's happened even without surgery, and this is now probably 2 years ago, this scan. He's never had surgery, continues on an ALK inhibitor, and is doing remarkably well, totally asymptomatic from that standpoint. All right, so to wrap it up, in the 19th century, fatal. The 20th century, we're starting to get better. And now I think the 21st century, we're really starting to make headway. And I think understanding the oncogenic landscape is absolutely critical. And the earlier we know what it is, the more helpful it is to stratify care and to ultimately determine if systemic therapy is going to be beneficial. There's even data now, I just reviewed an article, and there's a New England Journal case report in an adult where some of this oncogene-specific therapy improves radioactive iodine avidity by increasing NIS expression. That's been known for BRAF and MEK inhibitors, but it also seems to be true now even for RET and NTRK inhibitors as well, that if you use these agents, you can increase NIS and potentially increase the effectiveness of radioactive iodine. So we're working on the second guidelines now. We have 5 members in our CAT-C, but I have a large intramural grant from CHOP to not just build up our therapeutics program, but also to expand the CAT-C, which is the consortium I mentioned. We have at least 10 or 15 institutes across the country that are interested. There's also one in Australia. There's a group in Europe. And so the goal is that all of us work together, not just individual centers, to figure out how to take care of our patients in a more organized fashion and to improve their outcomes. That's our translational scientist, just to give her a shout out, because I'm happy and amazingly lucky to have Amy and be provided that opportunity. And this is the group at CHOP, at least just an endocrine that really helps me move these things forward. So with that, I will end. I think we only have 5 minutes, but I'm happy to stay longer. I'm on consult service, so I'm trying to hide from the fellow. But I'm happy to take any questions. And thank you again for your time and for listening to my hopefully interesting and exciting efforts that we have to improve care for children with thyroid cancer.
Thank you so much, Dr. Bauer. We do have some questions coming in.
Good.
The first question comes from Dr. Chet Whitley, who's in our genetics and metabolism division. Have you been successful in obtaining insurance coverage when a patient is referred to your center of excellence when the third-party payer views the institution as out of network?
Oh, I thought you were going to ask about Oncogene. So those are the two challenges.
That's the follow-up question that's coming your way.
So I'll do the Oncogene first and then the out of network. The Oncogene testing, the way we do it, because of that, we have the instant real-time read. If we identify, or the cytopathologist identifies that it's an indeterminate sample, we'll do the extra pass before the patient leaves the suite, and it's under conscious sedation. And then we have to see if insurance covers the somatic oncogene testing. So it's not all that do. In fact, sometimes when they don't cover it, especially some of the companies will only charge at most $300 if there's no insurance coverage. And if there is insurance covered, then they'll charge whatever your deductible is. Now, $300 is not a minimal amount for many families, but for some it's doable. So we struggle, and I think working together, building consortiums, maybe identifying centers of excellence, we can start to convince the insurance companies that it's helpful and it stratifies care and ultimately reduces cost, which follows into the next question, which is how do you get oftentimes state Medicaid, which are out of network, or other institutes that might be out of network. And we struggle. We have letters of medical necessity. We just sent 2 this week to try to convince out-of-network insurance companies to approve it. So essentially says we're a high volume center. We have reduced complications. The care ultimately will cost you less money and will ultimately, hopefully, improve quality of life and outcomes for this particular patient. But it's a major challenge in pediatrics, even at centers that are higher volume than some. So I've talked to Thyka a number of times, and there are other centers of excellence for brain tumors, for breast cancer. We probably need to start working again as a community to try to improve that for our pediatric thyroid cancer patients. Many of them do not need to leave out of network, but there are some that clearly would benefit. So I struggle. If you have any ideas, please feel free to forward them, or if you're interested in trying to work with us to try to fix this, I'd love it. We definitely need to work on it.
Yeah, I think that probably some opportunities for collaboration across specialties to face some of these challenges. There's a general
virtual line, hopefully, because we have a patient coming from California that, thyroid cancer, thankfully, is a relatively slow growing tumor. So with virtual visits, hopefully we can even set up networks where you might see them once a year and you work with their primary care in a virtual visit the other time of year or something. So hopefully there are some answers to this terrible COVID situation that we can keep using virtual visits to improve care. All right, next question.
There's a sort of general question about patients with P10 and should they be followed by an endocrinologist. And then Dr. Suni asked a very high-level question about P10 Hamartoma Syndrome and how you might manage nodules in that sort of patient and when you might biopsy in higher risk groups.
Right. So P10 is and DICER1 are quite similar. So years ago for P10, we would start doing ultrasounds at 18, and then there's a number of studies that came out and said there was some patients identified prior to 10 that had thyroid cancers. As I mentioned, most of these are indolent. So I think, yes, endocrine should follow P10 patients, and 2, when to initiate thyroid ultrasound, whether it's P10 or DICER1 or even familial adenomatous polyposis, is still a little bit up in the air. If you're comfortable reading ultrasounds, I don't see a problem in doing it earlier. If you're worried that you're going to identify a nodule, then you're not sure if you should do a biopsy and not comfortable, and the family's not going to be comfortable. You have to weigh that out, and the family just has to be educated that it's highly likely to find a nodule, and if we find a nodule, it doesn't mean it's malignant, but it may mean that it needs to be followed, and then you just have to decide to do the biopsy or not. Oftentimes, especially for P10, there'll be more than one nodule, and they won't have all the same cytologic or even pathologic diagnosis. So you can have mixed benign and less invasive tumors if it's the germline P10, not a somatic P10. So what we've done at CHOP just in September actually was our first P10 multi-D clinic. last summer we looked at, we had 80 P10 patients at CHOP over the years, currently 50 that are active. And so Susan McFarland from Oncology has set up a P10 Center of Excellence through the P10 Foundation at CHOP. And now we have a multi-D clinic once a month. They come in, they can see GI, allergy, developmental peds, GI, oncology, endocrine. I'm the endocrine person. And it's not every patient sees every person, but every patient is like, we identify who they have to see within the clinic. And then we decide, when do we do the ultrasound? What do we do with the ultrasound? Working together. So it depends on what your population is. But again, identifying a group that works together for patients with less common diagnosis hopefully improves the outcome and also just improves the comfort of not only for the providers, but for the patients as well, to help improve care. So we'll see what happens with P10. It's pretty uncommon to have invasive thyroid cancer in germline P10, just like in Dicer 1 for germline Dicer 1. So a little bit, you can't think about it in the same context as other predisposition tumors like MEN2, where if you don't catch it early, it's metastasized, and if it metastasizes, it's difficult to get rid of, if impossible to get rid of. In these differentiated thyroid cancer predisposition syndromes, you may identify a nodule earlier, but waiting isn't going to be as big of a risk and may actually be a benefit down the road for a patient that may ultimately have low to no invasive disease.
Wonderful. Thank you so much. We have been trying hard to start on time and end on time, so I think we'll have to wrap up now, but it looks like our endocrine group may have some follow-up things that they'd love to connect with you about offline. So thank you so much to everyone for attending.
At the bottom
today.
is my email and the Thyroid Center email, and that's where my nurse and nurse practitioner check emails too, so feel free to ask questions. I'm happy to answer them.
Thank you very much, Dr. Bauer. It's a pleasure to have you. It's a great talk.
Thank you so much.
Have a great day, everyone. Thank you.
Thank you so much. Thank you.
Thanks,
Wear
Mona.
masks.
Thank you.
Yeah, wear your masks.
Bye.